पेन ड्राइव है? इसे खुल गई, ठीक है, मैं खुल नहीं रही थी, ठीक है। मैंने फॉर्मेट की, इसके बाद गड़बड़ तो नहीं होगी फॉर्मेटिंग में। साइन करना होता है?
इसमें इधर नहीं।
मास्क पहनना है? मास्क पहनना है?
नहीं कोई
नहीं, इसके बगैर
अकेले को।
हाँ, ट्वेंटी 8 है ना आज, 2 PM गैस्ट्रोएंटरोलॉजी 27, सॉरी, तो कल वाला है सर्जरी। That 9, 6, 8, 5, 7, 7, 4, 6, 8, 6. एक्सक्यूज़ मी, स्टार्ट करने के लिए कैसे पता चलेगा बच्चे आ गए? इसमें आ नहीं रहा कुछ। ये वाला
नहीं, ये इस वाले में गूगल वाले, वो यहाँ से चैट करते हैं, इधर दिखाई देते हैं।
ये तो चैट है। नहीं, ये तो चैट वाला है।
वो इधर ही दिखाई नहीं देगा मैम, जो भी बच्चा आएगा ना।
हम शुरू कर लेते हैं।
हाँ
2 तो बज गए।
या हर्षिता मैम
अभी एक ही है ना, इसमें हम बात नहीं कर सकते इनसे।
नहीं यहीं पे कर सकते हैं, वो इधर ही करते हैं।
Good afternoon, students. I hope all of you are well and taking care of yourself. Today we are contributing from 3 different departments for this seminar, and myself Anita from Department of Surgical Disciplines, and Professor Alok Thakkar, he is head Department of ENT, Dr. Anchal from Department of Pathology. I'll be covering some basics about the salivary glands, a recapitulation of what you have learned in anatomy, then something about physiology, and coming back to the basic diseases of salivary gland, benign part. And I have following me Dr. Alok Thakkar, who will be teaching about the malignant part of the glands, and Dr. Anchal will give you the pathology part. Okay. So we all know that there are division like major and minor salivary glands. Major, we all know there is parotid, submandibular gland and sublingual gland, and there are number of other glands in the name of minor salivary gland, right? So let's just recapitulate our anatomy. We have read few years back, and this is what is the parotid gland. What is the relationship? Above it has external auditory meatus and the temporomandibular joint here. Then below is the posterior belly of digastric and the mandibular and masseter. This is the masseter muscle anteriorly. Mandible is along with it. You can see this bony part that goes anteriorly, and medially behind this is the styloid process, along with the attachment of the muscles that come up to the styloid process, stylohyoid, stylomastoid, all these muscles that are there. And also internally there is internal jugular vein, there is internal carotid artery, and last 4 cranial nerves, and the lateral wall of the pharynx. So the second part is of importance, which goes for the surgical part also. This is the layout, the line diagram of the parotid. This is the lobe of the ear, and then we know the facial nerve exits as it comes out from the foramen, and then in the relationship with the styloid process, anterior and downwards it moves and splits into 5 branches. 2 trunks mainly, upper and lower, and then divisions. The importance of as surgeon, as the surgical case, is that the nerve, the preservation of nerve, or first of all the involvement of nerve, whether it's a benign thing or malignant, the entrapment of the nerve along with the tumor, and the consequences of that. Patient may present with a deviation of the mouth, or may have some weakness in the upper lid. So that gives us a clue about the whether the nerve is involved. So this is a typical, the parotid gland has not been divided truly into superficial and deep, but it's the fasciovenous plane of Patty that divides into a surgical, that is surgeons take advantage of this division. Because of the nerve it traverses inside, upper and lower lobe is divided according to that. So this is the importance from the surgical point of view. Then this is another view of the same, and the cross section showing the deep structures above and below it. We have already talked about it. Then about the duct, there are many problems. All the problems are not related only to the gland. and many of them are related to the duct itself. Duct can have a luminal problem and can have a wall problem, a wall related problem, the duct itself, and at the exit of the opening in the mouth, that can have problems. So various disorders can come up because of the duct, and we all know how it traverses on top of the masseter and then sinks down between the buccinator fibers and finally opens in the upper part, second upper molar tooth near that. Submandibular gland, it's little different from parotid gland. It's again a large superficial lobe and it has a deeper lobe. The division of this, you can see this diagram here, this is the mylohyoid muscle, and then the above part and the deeper part is, it gets impinged between due to this mylohyoid muscle and creates a deeper and a smaller deep lobe. Again of surgical importance, because if we do only of the surgical superficial part, we can leave a small part of the deep lobe inside. That can have its own issues, problems, and if you are doing it for malignancy, we know that the best results are when we remove the gland in its entirety and along with the tumor. So we should know about, fully know about the anatomy of the organ which we are removing. Superficial lobe lies at the angle of the jaw, wedged between the mandible and the mylohyoid, and overlapping are the digastric muscles. And we already talked about the deep and superficial part. The duct with the Watten's duct name, and it goes superficial to the mylohyoid and adjacent to the lingual nerve. So we have two major nerves here, the lingual nerve and hypoglossal nerve. It's almost 2 to 4 millimeter diameter, 5 centimeter in length, and opens at the floor of the mouth. Again, since it's in the dependent part, like the gravity plays a very important role in the problems related to the submandibular gland, and the punctum that is in the floor of the mouth also has the design is so that the opening has narrowed. Only the physiologically it can be active when the saliva has to come out. The retrograde things go inside, like enter into the duct only in an abnormal condition, which gives rise to problems and the infection. This is how it looks, the submandibular gland in relationship to the nerve and how it enters through the floor. Then we have the sublingual glands. The ducts, they open in the floor of the mouth, and the ducts are called as Bartholin's ducts, and there are almost 8 to 20 smaller ductules in the ducts of Ravenous. This you already know how what is the normal 1 to 1.5 liters of saliva is always poured out from various salivary glands, and the make of that 99.5% is water and other contents. Will not go in the detail. It lubricates the mouth, helps in chewing and other things. This is the nervous autonomic nerve innervation. How the stimulus comes from parasympathetic and sympathetic nerves to it. The investigation part, whenever we have any problems with the major salivary glands, very extensive investigation is not required, but the ultrasound plays a very important role. In fact, ultrasound is now designated as an extension of the clinical examination. The clinical examination is of great importance. I'll give you some clues along the disorders as we go on. And ultrasound is considered as an extension of the clinical examination now. And it is a non-invasive modality of looking at deeper structures, and it gives us echoes which have a significance. It reflects. The reflection comes from either it's an inflammation of the gland, or it's an abscess, or there is a stone. According to that, the signals come from it, and the echoes, reflection of those echoes they produce a beam of high frequency sound waves that is recorded, and we interpret them what kind of problems this gland has. Then we have the identification of the duct. We put in place through retrograde injection a water soluble radio-opaque fluid inside the duct to identify it and shoot an X-ray for that, so that it gets delineated. That's for sialography. The plain radiograph may be required initially. There are stones that are radio opaque that can be seen on the glands, and then we inject this and see the duct. What is the importance that if there is a stone in the duct, it can give a the dark appearance, and the filling defect may be there. So the radiologist will tell you, okay, there is a filling defect and there is a possibility of a stone there. These are few views, you can see them. This is how it looks. This is a condition where it was a dilated duct, and you can see we have just now seen that it may not be more than 4 millimeter dilated in the normal the size of the duct, but here you can see it's much bigger than that. Then we have other modalities like CT scan and MRI. The indications are very specific. Every case will not have these investigations. The extent of the tumor, if it's a big tumor, clinically you cannot make out what is the size, how far deep it's going, and then we cannot judge whether the extraglandular extension is there or not. These are two main things. Then if the gland and the tumor is so big that it's reaching to the laryngeal wall, parapharyngeal spaces, we do not know whether it's arising or it's coming from deeper to outer. These are the special cases where MRI can help or a CT scan can help. Then if there is tumor, it's a malignant tumor, whether the lymph nodes are involved or not. So we need to do these tests. Then there are certain conditions where minor salivary glands can have problems. It's not so easy to identify minor salivary gland issues which are little deep seated. In those cases also it can help us. This is one view of MRI where the duct has been seen. It appears dilated and big. Then we can have radionuclide studies. These has very specific importance. Technetium 99M is used, and to identify the inflammatory conditions such as osteomyelitis, areas of any disruption, whether it's a inflammatory condition or there are certain skeletal disorders along with it. There are conditions when it can erode the bone, very extensive disease, locally advanced. There are so many conditions, variety of the spectrum that you can see of a simple disease at times. Then the most important thing is getting an aspirate and getting the cells to be seen under microscope to find out what is now the condition, whether it's a benign condition, whether it's a malignant condition, or it's just an inflammatory thing. Sometimes the glands increase in size due to chronic inflammation, and we can pick up some pus cells and see it under microscope. Then there are techniques where you can go through the duct and identify them. So just like endoscopes, you can go through these ducts. These are the pictures where you can use instruments also. Very delicate method of doing it. Not every center has facility and every person can do it. It's very skilled job to do these such things. These are the very fine instruments that can be used along with it. This is the inside view. You must have seen how esophagus is seen endoscopically and how the colon is seen. There's something like that, how we see the duct inside. Then what are the diseases we come across? Salivary glands are divided into mainly functional disorders related, obstructive, there's a block that gives rise to the problems. Then whether it's malignant disorder, there is a mass there, whether it's malignant or it's a non-malignant or a benign condition or an inflammatory condition. So what happens to the saliva? There are two conditions, named conditions, where the flow of saliva increases, and there is another where it decreases. The sialorrhea, the patient keeps on dribbling the huge amount of the saliva that's produced in the mouth. There are certain conditions like psychosis, mental retardation, neurological condition, rabies. You must have read about the mercury poisoning and all forensic medicine. Then where dryness of the mouth because of lack of the saliva itself. There are conditions like mumps, Sjogren's syndrome, lupus, post-irradiation, post-radiotherapy. There are malignancies in and around head and neck area where you have to give radiotherapy to these patients for having local control of the disease. That can indirectly cause an insult to other areas. For example, the salivary glands. There is dryness of the mouth. Patients keep on complaining after that because the cells, the salivary glands get irradiated, and that gives a side effect of the radiotherapy. Then post-surgical, glands have been removed due to some reason, the saliva is less. Then we come to a specific condition, mucocele. Mucus is the exclusive excretory product of the accessory, for example, minor salivary glands, and the most prominent product of, for example, sublingual gland. The mechanism for mucous cavity development is extravasation or the retention. Two things can happen. It can move out or it can get blocked inside the gland. So it can be secondary to trauma, or 70% of the cases and are seen in actually in the lower lip. We know that lower lip is more exposed to trauma. So these two conditions, you can see a picture here of the lower limb. Treatment is excision with strict removal of the associated minor gland. If the gland is culprit, you have to be careful that it's removed and blocked along with it. Then avoid injury. While we are doing this, it's a very delicate procedure where you have to be careful that while giving improving the present condition, that is the mucocele, you should not create many more problems by injuring the adjacent structures that may have ducts of other minor salivary glands. Another few pictures you can see here, they are all mucoceles presenting in different form and locations. Then a condition called ranula. It's a term used for mucocele that occurs in the floor of the mouth. The term is derived from rana. We know that this is a specific term used related to this condition, and it's because of the look of this frog. If you open the picture of this frog and now identify, you may not have seen it earlier, you will find how it hangs in the lower part, and the swelling may resemble, and it's a translucent underbelly of the frog. It presents like a blue dome shaped swelling at the floor of the mouth, tends to be larger than mucocele and can fill at times the whole of the floor of the mouth with elevation of the tongue. Right? It may be located, it's usually located to one side, lateral to the midline, helping to distinguish, because patient does not come with a diagnosis. You have to make a differential diagnosis. Okay, now what are this condition? Do I know the diagnosis? So we'll differentiate from other conditions. You exclude other conditions. For example, a dermoid cyst in this location. We know that dermoids, they have a specific location in the midline. So if this swelling is found to one side of the midline, to lateral to the midline, then we know it's not dermoid. And if it's in the midline, then the differential diagnosis of dermoid can be there. So always have a differential diagnosis for any patient you find clinically, that these are the findings. And then how do we narrow down? We narrow down by exclusion criteria. Now this has specific characteristics of this disease, and then we know how to exclude the regions. Plunging or cervical ranula occurs when spilled mucus dissects through the myohyoid muscle and produces swelling in the neck. It has both. It has a floor of the mouth lesion also, and it will have a visible swelling also. So the diagnosis can be made by looking at the external view and also opening the mouth and seeing this condition. This is how it looks, right? What is the treatment? Earlier, de-roofing and marsupialization of the cavity would be done. This is not done now. It's why? Because of the high recurrence rate. Now, what is the improvisation of the technique is that you have to remove the the culprit, the whole gland. If the sublingual gland is to be removed, and approach is through the intraoral route. Then we come to the obstructive conditions. These are due to the stones, the sialolithiasis. It results from mechanical obstruction of the salivary gland duct. It's a major cause of unilateral diffuse swelling of the gland, and there will be a swelling. Patient will say, when I eat, there is swelling of the gland, right? The exact pathogenesis of this actually is not known, but there are certain nidus, the stone that we remove from the surgically. When we remove it, we can send it for the chemical analysis, and when we see it, we found that there may be an initial organic nidus inside, and it's wrapped with an inorganic material or organic substance. So there is a nidus that triggers off it and gets wrapped with other products. So the chemical make of the stone will tell you about the cause. Eventually it blocks the duct and leading to the condition. So there are certain medicines that can lead to this problem. There are tobacco smokers. They have found to be have a positive correlation with formation of more stones. Right now we come to reasons why it occurs more in submandibular gland as opposed to parotid gland, and the few conditions that are known are saliva is more alkaline, higher concentration of calcium and phosphate has been seen in the saliva that comes out from the submandibular gland, higher mucus content is there, the duct that comes out from the gland and opens finally at the floor of the mouth has a little longer curved the root, and obviously it goes in an anti-gravity flow. And what does it do? It is more the symptoms come up. Patient will say, I have a painful swelling when I eat, and then it settles as it is acute. But there are certain conditions when they become chronic. Every day patient has problem and it becomes then finally attains chronicity. The size of the gland remains big. Gradually reduction of the swelling occurs as the time passes. This may continue until there is a full block. Now, despite similar chemical makeup, we know that submandibular gland has 80 to 90% of the submandibular calculi that can be seen radio-opaque if we shoot an X-ray, whereas 50 to 50% only parotid calculi are seen. The number of glands, the stones are much more. 60% are multiple in parotid gland. The submandibular have multiple in only 30%. So the various chemical structures we saw the reason. This is a diagram showing single duct, a single stone here, then two stones, multiple stones. This is how it goes. The most important management is removal of the stone. If it's in the track, we remove it if it's accessible. But if it becomes chronic, the gland becomes diseased, and the glandular part has stones, it's not possible to remove it. And then if it's also associated with multiple strictures, the complications of stone, then we have to remove the gland by itself. This is a gland that has been removed here, and these are the stones removed. We saw the composition. This is a look at this, the organic material that can form the nidus, and this is the inorganic material that can be a covering part, the peripheral part of the stone. So we talked about whether we should remove it intraorally or externally. Preferred is intraoral route or the transoral route removal, and whether gland should be removed or not, we have already talked. The gland excision is indicated when the stones are more posteriorly intraglandular and failed transoral. Sometimes we remove the stone, but it leads to the stricture or the narrowed, the luminal block later on, and it forms a chronic. So failed transoral approach, the stone removed, chronicity, recurrence, that is another reason for removal of the gland. Then coming to the infections, it can be an acute bacterial infection, acute bacterial sialadenitis, or chronic bacterial infection or viral infection. Most common you have known about mumps. Acute infection, they are more affected in major glands than in the minor glands. The retrograde contamination of the salivary glands and parenchymal tissues by bacteria inhabiting the organisms are already present in the oral cavity that can retrogradely contaminate it. That's why we keep on reinforcing the sick patients. They are given constantly oral hygiene is, they are given mouth washes and all, so that the glands don't get involved. And we all know the organisms are already there, and we stop brushing, we have poor oral hygiene, all these factors can lead to this. Stasis of the salivary flow through the ducts and parenchymal promotes acute suppurative infection. Then we know suppurative parotitis, we know the surgically induced sometimes, and the post-operative, again there is injury to the duct, there are certain tumors that are very close to it, then the mumps, the pyogenic parotitis, they are all different common type of the parotid glands getting involved in suppurative type. The etiology is associated, this 20% of them are bilateral. Risk factors are systemic dehydration. So stasis with dehydration can lead to it. So we have to keep on hydrating such patients and also give instruction to them. Then chronic disease or immunosuppressants, liver failure, renal failure, diabetes, hypothyroidism, then elderly patients who are debilitated, bedridden, malnourished, they are all reasons that can go in for the formation of the infection in these glands. And we know neoplasms, pressure occlusion of the duct can be one reason, right? Patient may come actually with pain, but the gland was a problem, a mass was there for few more months, he didn't bother to come, but pain brought him to the doctor, right? Then coming to the presentation, it can have a rapid onset, pre-auricular swelling, patient can present with erythema, pain, and we can have on palpation, if patient allows us, we can see pus coming out from the duct in the mouth, if patient allows us, though it's a very painful condition. And the discharge that comes from the duct can be sent for culture sensitivity. Staph aureus is the most common organism seen. Staphylococcal aureus, Staphylococcus pneumoniae and Pyogenes can be seen, and Haemophilus influenzae is also common. Lab tests can be done, and the ultrasound again can be used if there is a pooling, there is a pus collection or not. Antibiotics are initiated. 70% of the organisms, they produce beta-lactamase or penicillin, or beta-lactamase or penicillinase. So need beta-lactamase inhibitor like augmentin and other related products, or cephalosporins should be given. Can also be considered metronidazole should be given, or clindamycin can be given to cover the broad spectrum coverage. Then coming to the parotid abscess, it's a tense swelling. It can have toxemia if it's ignored. Usually there is no fluctuation in these conditions because of the dense parotid fascia and the gland. Sometimes it gives rise to that. You can't, usually in abscesses you can do a fluctuation if the fluid and the pus is there. In this condition it presents as an acute onset with severe pain, intense pain, and when you do a ultrasound you will see pus is there. The drainage is the only condition. You can aspirate it, but sometimes there is a need for drainage. The drainage has to be very carefully done because the nerve branches are there, and you give an incision in a horizontal way, so that not in the perpendicular way. So you know the nerves, how they pass. So you have to give an incision along their proposed curve. So you go along with it. The chances are that the nerve branches, they escape your incision. You don't have to go deep, and the pus drainage is done, which is at times very important. Minor salivary glands, there are 600 to 1000 minor salivary glands all over the place. So not of great importance unless they tend to have disease and present with some the tumors there. Approximately 1% of, now coming to the neoplasm, 1% of the head and neck lesions, they are in the salivary glands. 6th decade is the commonest of them, and malignancy usually comes after 60 years, and benign lesions are usually present before the age of 40 years. Both genders can be equally involved. And parotid gland, almost 80% of them is seen in parotid glands, as against 10 to 15% in submandibular gland. Sublingual and minor glands take the remaining percentage. The commonest in the parotid gland is the pleomorphic adenoma, almost 60%, and submandibular, almost 50% of them are malignant. And we know that the initial history taking is very important. See how the mass has progressed. Record the history of the growth. Is it sudden? It is slowly growing? What are the symptoms with meals? Whether there is a facial nerve weakness or not, whether the patient is able to close the eye during night, the family members may have observed, whether there is deviation of the mouth, the association of the pain along with it. All these history points are to be recorded. And majority of the patients with salivary glands, they are slow growing, painless lesions, and they may present very late at times. And submandibular glands, they are usually diffuse. The sublingual tumors with bimanual palpation should be done in such cases to rule out whether it's outside, inside. That is, when you come for the clinical classes, we'll let you know about the manual, how to do all these procedures. Then adenomas or the epithelial origin tumors, they can be a pleomorphic adenoma, monomorphic adenomas, adenolipomas, oxyphilic adenomas. All this will be talked about in pathology also. Regarding the mucoepidermal tumors and this, see how they look at times. These are the views from inside. So you have to examine the patient from outside and also open the mouth to see whether there is an intraoral extension of these tumors. Pleomorphic adenoma is the most common, and the pathology part will be covered by Dr. Anchal. So the most important treatment is the surgical excision. As I said, most of them, the bulk is in the superficial parotid gland, and superficial parotectomy is the most important the treatment of choice for these lesions. And for example, for the Wadim's tumor, it's also called as adenolipoma, lymphoma. The local excision is the treatment of choice. And superficial, I'll show you this picture. These are the nerves. The top gland part has been removed. You expose the trunk first, and then follow each branch, and then till the superficial gland gets lifted up. Actually, you follow the nerves. The nerve branches are seen. While you are exposing the nerve branches, the superficial gland is completely lifted off. Most of the times, superficial parotectomy treats most of the benign conditions of the parotid, pleomorphic adenoma especially. And the Wadim's tumor, its local excision only is the treatment of choice. I'll request Professor Alok Thakkar to continue with the malignant part of the salivary glands, and he will give you the details. He will join you in few seconds. Thank you. So we need to load it. He told me to see it here. Okay. Thank you.
So I just have to load my slide.
You need to sign it here.
Okay.
Put it on the desktop and open it. This can be minimized.
What can you minimize?
No, that's okay. I think it can go on.
Yeah, I just want to see. Okay. So
tell him to check.
So can you hear me? And can you hear me? And can you see me? How do you open the chat? Yeah.
Yes, sir. So you can go on.
Okay. So how many of you are there? Can I? Okay, can we know or can we not? 26 it seems, yeah, or 5. Concurrent viewers 5. Okay, good. So anyway, so you need to tell me how do I know if one of them has a question? There is no way you can. So you will have to open it again, no?
Yeah, you can go back to this. Your presentation is here.
Okay. So tell me, is this a malignant tumor or a benign tumor? So was that malignant or benign? Yeah? So obviously it's difficult to communicate. Anyway, so this is obviously a malignant tumor, but the point I wish to make was that there are clinical signs of malignancy, but you can miss malignancy also. So the clinical signs of malignancy are pretty obvious. This is a T4 tumor, there's skin involvement. So if there's skin involvement, if there is attachment to bone, if there's attachment to the base of skull or the ear canal, that obviously indicates to malignancy. Also, if there is severe pain, it indicates to malignancy. If there is lymph nodes, it indicates to malignancy. These are points you need to note because you need to know these points. If there is facial nerve weakness, it's an indication for malignancy. And of course, like you read in your surgical books, if there is variable consistency, then that also is an indication for malignancy. But the point is that there are many parotid tumors which will display none of these signs and yet be malignant. So any tumor you find, even though it's mobile, is painless, is not associated with facial nerve palsy, is not associated with lymphadenopathy, does not mean that it's a benign tumor. You should do an FNA, and in FNA, though it is 90% sensitive to pick up malignancy, it's not a 100% situation. So basically any patient with the malignant disease may present with a benign presentation. So the first question you need to ask yourself when you see a patient with a tumor is it benign or is it malignant? The second question you need to ask yourself is this a superficial lobe tumor or is this a deep lobe tumor? So here's a patient who has a deep lobe tumor. Why is it deep lobe tumor? Because you can see that bulge intraorally. So you know that the parotid is divided into two bits, the superficial lobe and the deep lobe. And you also know that there is no real compartmentalization from the anatomical or embryological point of view. But we call it so because anything that is superficial to the facial nerve we call superficial lobe, and anything that is deep to the facial nerve we call deep lobe tumor. The reason for that is entirely surgical convenience and the degree of surgical and difficulty and the surgical morbidity that you get with the excision of such tumors. Most deep lobe tumors are silent. You will not see them clinically. But at the same time, if you come to an exam and you don't look for the signs for a deep lobe tumor, then you have obviously not done your job. So what are the signs for a deep lobe tumor? The signs for the deep lobe tumor is primarily a bulge intraorally. You will generally see it behind the tonsil. So behind the tonsil, the lateral pharyngeal wall posterior to the tonsil will be bulging medially, and you can sometimes see it, or if you do a bimanual palpation or a ballotable test wherein you put one finger inside the mouth and the other in the retromandibular area and ballot it, then you might be able to ballot the tumor or bimanually palpate the tumor, which are again signs of deep lobe involvement. So any patient with a parotid tumor, you should look inside the mouth, and you should look and you should try and ballot and feel. This is radiology. So this is the same patient as you see out here with the radiology, and you can see this huge intraoral bulge with the tumor which is on the deep lobe of the parotid. Today it is generally becoming standard to do scans for patients who have parotid tumors, because it is important to know whether it's a deep lobe tumor or a superficial lobe tumor. Both of them are treated by surgery, but I think patients like to have prognostication as to what kind of operation they are going in for, what kind of morbidity can they anticipate. So this is a standard diagram, was part of my Bailey and Love. I don't know if it's part of your Bailey and Love, but this shows the facial nerve coming out from the base of skull. You can see the styloid process, and the facial nerve comes out a little bit lateral and posterior to the styloid process of the stylomastoid foramen, and then divides into 5 bits, usually what we call the pes anserinus, which basically means the foot of a bird. So you can see that this looks like the foot of a bird, and you can see the different branches of the facial nerve, the one that supplies the forehead, the one that supplies the eye, the one that supplies the upper lip, the lower lip, and the neck, or the platysma in the neck. This is the diagram we have seen before, with anything that is lateral to it, all parotid tissue lateral to it being superficial lobe, and anything that is medial to it being deep lobe. The important point is that this is this nerve, which is this vein, which is the retromandibular vein, which is in close relation to the facial nerve, and the retromandibular vein and the facial nerve generally attach to each other with the vein deeper. So though we can generally by imaging not see the nerve, we can see the vein on imaging, and it serves as a de facto quasi marker for deep lobe and superficial lobe tumors. Anything that is deep to this vein is called as deep lobe, anything that is superficial is called as superficial lobe. You can very occasionally go wrong, but almost always you will not. So this is an operation which is showing a superficial parotidectomy. You can see the ear there, you can see the facial nerve, and you can see the superficial part of the parotid gland where the tumor is being taken away. What you see here is the posterior belly of the digastric, and the reason I show this diagram is because it illustrates to you the standard landmarks for the facial nerve when you do a surgical operation, and this is sometimes asked in the exam. So what you see here is the cartilaginous ear canal. The dissection is done between the cartilaginous ear canal and the parotid in front, and this is what we call the tragal pointer. And tragus, because of course the ear canal, you have the tragus in front of the ear, in the auricle or in the pinna, so the tragal pointer, and this is the cartilage, and as you follow this cartilage down medially, it will come to its junction with the bony external auditory canal. In the medialmost part of this cartilage is what we call the tragal pointer, and the nerve is a centimeter deep and maybe a little bit inferior to it. Deep and somewhat inferior, a centimeter deep and inferior to this, you will find the nerve trunk exiting from the stylomastoid foramen. This is the diagram which again shows the bony ESC, and you can see that will be a centimeter below and inferior to the bony ESC, the start of the bony ESC or the end of the cartilaginous ESC. What you see here is the posterior belly of digastric, and this nerve will be just above the posterior belly of digastric, and here the same thing you see surgically. So you see the posterior belly of digastric, and you can see the vein above it, the nerve above it, and these are two essential landmarks that you should be aware of even as undergraduates. What you see here is the deep lobe of the tumor, and the deep lobe, you can see that here is the facial nerve, and under it is basically the retromandibular vein and the external carotid artery. And these are again important to know, because if you have a tumor which is deep to the facial nerve, then the morbidity, as I said, is significantly greater in terms of excision because of these structures, and also because just the excision deep to the nerve involves retraction of the nerve, which causes significant morbidity. What you see here is again the tragal pointer. You see it so well, the cartilage of the external auditory canal. Finishing here, this is the point you call the tragal pointer, and then a centimeter below and inferior you will find the nerve trunk. Something similar, the facial nerve and the deep lobe being excised. This is a patient who has a deep lobe tumor, and you can see that the branches of the facial nerve are looped along these neural slings. These are soft rubber slings that we use at surgery, and the tumor basically has to be delivered between these branches or under these branches. So naturally there has to be retraction of the branches, and this leads to morbidity. You see the same here, the nerve branches going over the tumor. So this is a deep lobe tumor, and the nerve branches are going over the tumor. If you remove a deep lobe tumor, you can anticipate some morbidity in terms of a transient facial nerve paresis. So now you have already been told about deep and about benign and malignant tumors, and Dr. Anchal will be coming in again to give you in greater detail what is a malignant tumor and the basic classification of malignant tumors. And there is a lot of development in that area, but basically we tend to look at it as benign and malignant. As has been already said by Dr. Dar, the benign tumors are basically the pleomorphic adenoma and the Wadden's tumor. Now what I am saying here is not in slides, so please listen and if necessary take notes. The pleomorphic adenoma, commonest benign tumor seen in the parotid and the salivary and the submandibular gland, and can be in any of the minor salivary glands. The general rule of thumb is that the larger the gland, the less likely to have a malignant tumor. So parotid 20% are malignant, submandibular gland 40% are malignant, sublingual 50%, and minor salivary glands, which are small glands which are not generally easily seen but are present in the hard palate and the soft palate, in the oropharynx, in the larynx occasionally, in the nasopharynx. So these are usually malignant. If you have a tumor in these, you will be usually malignant, minor salivary gland tumors. In the parotid, as I said, 80% are benign, and most of them are pleomorphic adenomas. A pleomorphic adenoma is a bossylated tumor. That means that its surface is not smooth but has small nodular things. As you can see out here also, you can see the small bossylations or the nodularity on the tumor. And for this reason, we prefer not to do a very close excision of the tumor, but to do a wide superficial parotidectomy where you use a huge cuff of parotid tissue around the tumor as you excise it. So if it's feasible, it's always nice to skim along the facial nerve and remove all the parotid tissue lateral to it with the tumor. That is what is a superficial parotidectomy, and that is the standard operation that is done. So you remove all parotid tissue lateral to the facial nerve with the tumor. That is a superficial parotidectomy. That is the basic operation we do. For patients who have benign tumors of the deep lobe, we do a total parotidectomy. So you first take out the superficial lobe for access, and then you go ahead and remove the deep lobe with the tumor to remove the tumor. When you generally remove a deep lobe tumor, you often have to remove the external carotid artery, which is here, and of course the retromandibular vein. So you will have to probably clip the external carotid artery in the deep lobe and the retromandibular vein, and that would be a total parotidectomy. For most malignant tumors, we work similarly, though there is some controversy for malignant tumors as to whether a total parotidectomy should be the minimum operation for a malignant tumor. It is not our usual practice. For tumors which are malignant, we generally do either a superficial parotidectomy or a total parotidectomy. But yes, the threshold for a total parotidectomy is lower, and there is a school of thought that all malignant tumors should have at the minimum a total parotidectomy. That is not our usual practice. Most of our patients will get a superficial parotidectomy. Then there are patients who have tumors which are infiltrating the facial nerve, and these patients get a radical parotidectomy. So superficial parotidectomy, total parotidectomy, and radical parotidectomy. In a radical parotidectomy, we would also cut the facial nerve. So you remove all parotid tissue and cut the facial nerve. That obviously gives you the best excision, the best chances for cure, and if it is necessary, it is necessary, and that would require sectioning and loss of facial nerve function. We tend to look at malignant tumors as clinicians in three broad categories: low-grade tumors, intermediate-grade tumors, and high-grade tumors. So low-grade tumors are tumors which are generally the acinic cell tumor and the low-grade mucoepidermoid tumor. Intermediate grade, you will have maybe the adenoid cystic and the high-grade mucoepidermoid, and in the high-grade tumors you would have squamous cell carcinoma and undifferentiated cancer, or carcinoma ex pleomorphic adenoma, which basically means that a patient who had a pleomorphic adenoma has had a transformation into a malignant tumor. These are generally aggressive tumors. The chances of a benign tumor in the parotid transforming into malignancy is not clearly defined, but generally believed to be in the range of 8 to 10% as a lifelong risk, which is obviously another reason as to why these patients should not be ignored. Now coming on to what is new with salivary gland disease, so I'll introduce you to a few things. What you see out here is MR sialography, or rather sialography. Sialography was when we used to inject into the duct a dye and take a picture to try and localize if there was any obstruction or if there's any calculus. And nowadays we tend to do this with an MR. So with an MR or a T2 weighted MR which picks up fluid, you can actually see the duct very well, and you can also see the stenosis. The advantage of this is not only that it is non-invasive, the other big advantage is that you can see both distal and proximal to the obstruction. So if you look at the previous picture which had only a sialogram, then you can only see proximal to the obstruction. You can't quite see distal to the obstruction, because when you inject, you can only inject as far as the obstruction. When you inject from the mouth of the duct, you can only inject as far as the obstruction. But when you do an MR sialography, you can see both sides. This is another patient with a dilated duct, so you can see there's an obstruction here and a hugely dilated submandibular duct. This is the other side, which is pretty normal. So MR sialography. This is a sialendoscope. A sialendoscope is nowadays being used for ductal pathology. So you can put in a scope through the duct of the submandibular gland, usually, which is in the floor of the mouth, and you can travel down it and sometimes remove calculi which are less than 5-7 millimeter in size and dilate stenotic areas. And this can prevent cure patients who have stenosis or calculi and or having recurrent sialadenitis as a result. What you see here is facial nerve monitoring. This is what we use routinely for parotid surgery nowadays. So this is EMG monitoring. This is a patient who has these electrodes inserted into the muscles around the eye and around the face, and during the operation you can stimulate the nerve when you see it, to try and ascertain as to what its function is. And of course its greatest use is when you have difficulty in finding it surgically. So using a facial nerve monitor can help you to prevent facial nerve injury, and more importantly, especially when you're working in deep lobe tumors, to warn you as to how much of the retraction is safely undertaken while you're removing a tumor. So this is how it tends to work. You stimulate the nerve and it So lastly, I want to show to you this patient who's had a facial nerve sacrifice because she had a radical parotidectomy as a young girl with a high-grade mucoepidermoid cancer, and she's been rehabilitated by facial nerve. And I would do this talk for you again if you come for my facial nerve lecture, which I take for the 8th semester. And what you see out here is a piece of heavy metal, generally gold, which is a 24K gold, which is inserted into the upper eyelid as part of the treatment for facial nerve paralysis, so that they can have a normal blink, and also a hypoglossal to facial nerve anastomosis, which is enabling return of facial function after nerve sectioning. So thank you. If there are any questions in the chat, I will take them. Good, one of you answered malignant. Very good. Why is deep lobe silent? Does it not compress the facial nerve? Good question. So a deep lobe is basically the lobe which is deep to the facial nerve. It may not compress the facial nerve. It just stays deep to the facial. It just stays in that tissue which is deep to the facial nerve. And so diagrammatically, this tissue which is on the medial side of the facial nerve is the deep lobe tumor. This is the deep lobe. And you can have a tumor out there without causing any problems. They generally come to light late for this obvious reason that they stay in this potential space and don't quite come to light till they're fairly large. So when you see a tumor in the retromandibular space, you're never quite sure if this is superficial to the nerve or deep to the nerve. And most are superficial to the nerve. 80% tumors are superficial tumors. But you don't quite want to go in for surgery and be caught with a tumor which is unfortunately deep to the nerve, and so the patient will have more morbidity than anticipated. So good, I'm glad you asked the question. But as I was emphasizing, as clinicians or as someone who sees a patient like this in an exam, two questions you need to answer. One, is this malignant? And realize that the answer to it is not easily available clinically, but nevertheless you have to try. And the second question is it a deep lobe tumor? And again, the answer to that is not easily available clinically, but you still have to look, and you can't miss it if it's obvious clinically. And you should do a cytology, of course, to make sure that it is that it's malignant or benign. Very sensitive, but not 100%. And you should do radiology in today's day and day to make sure as to whether it's superficial or deep lobe. So thank you.
Okay, good afternoon. So you've listened to the clinical aspects about salivary gland lesions. Now I'm going to discuss the pathology. And as ma'am and sir have already mentioned, one of the very important diagnostic modalities for salivary gland lesions is fine needle aspiration cytology, which gives you which you require, as it's often very difficult to diagnose a lesion in the salivary gland preoperatively, even based on imaging. So we have this imaging, but we have this diagnostic modality of fine needle aspiration cytology. Is my screen visible? Yes, it is. Okay. So we know that we have 3 pairs of major salivary glands, which are the parotid, the sublingual and the submandibular gland, and we have many minor salivary glands which are located in the oral cavity. So what these glands are composed of are acini, which are the structures which produce mucus and lysozyme, and you have serous acini, you have and you have mucus acini, and you have mixed acini as well. And these acini, they drain their secretion into ducts. First you have the intercalated duct, which join to form the striated ducts, and then finally an excretory duct. Now, why it is important to know the histology of these structures, the salivary glands, is because the tumors that occur in this location are going to arise from the cells that are present normally. Now, we also have another type of cell around the acini, which is the myoepithelial cell. So, myo implies that they have a function like muscle. So, what they do is they basically squeeze the secretions out of the acini into the ducts, and the ducts are surrounded by basal cells. So basically you have 2 types of cells. You have the luminal cells which secrete and carry the secretions forward, and you have the abluminal cells which basically support and permit the movement of these secretions forward. And when we go on to the classification of salivary gland tumors, you will see how they arise from luminal and abluminal cells. So as already discussed, salivary gland lesions, you have a number of neoplastic lesions which could be inflammatory, that is infectious or immune mediated or reactive. And then you can have neoplastic, which include benign as well as malignant tumors. So first we look at the non-neoplastic diseases. Sialolithiasis. Sialo means salivary and lith means stone. So sialolithiasis refers to the presence of a calcified mass or a stone in the duct or parenchyma of salivary glands. This results from mineralization of entrapped debris within the ducts. What happens is you have a central focus of bacteria which grow on inspissated mucus or some foreign material, and then calcium keeps getting deposited on it. This is more commonly seen in the submandibular gland as compared to the others because of the high calcium content of the secretions within this gland. So here you can see this is a salivary gland. You can appreciate the normal gross appearance where you can see the lobulated appearance. You can see small lobules and you can see the ducts, and here you have this yellowish mass here is seen within the lumen of a duct, and that is a stone which is causing obstruction. So once these stones cause obstruction of secretions, obviously the secretions are going to build up within the gland and the duct, leading to swelling, induration, destruction of the parenchyma of the gland, and chronic sialadenitis, which is secondary to the stone. What we see on microscopy, so this is the gross appearance. On microscopy you basically see round to ovoid structures with concentric calcified lamination. So they are basically small stones and accompanied by dilation of ducts. And whenever there is any chronic irritation to an epithelium, you know that it undergoes metaplasia. So can someone tell me what metaplasia is? I won't wait for you to reply to that. I'll go on, but I'm going to check. So you can get squamous, mucinous or oncocytic metaplasia in the cuboidal to columnar epithelium of the ducts. Then this will then be followed by fibrosis, acinar atrophy, and because of the absence of salivary secretions, it leads to mucositis because the mucosa of the oral cavity becomes dry. So this is the microscopy. You can see here when this blue material that you're seeing is stained blue because of the presence of calcium, and you can see the concentric laminations. And here this is on fine needle aspiration cytology. Also you can get these small fragments of stones which will help you to make a diagnosis. And here these are the epithelial cells which show some kind of reactive atypia whenever you have any chronic inflammatory or irritating condition. Next we will go on to cystic lesions of the salivary gland. Non-neoplastic cysts account for about 6% of diseases of the salivary gland. There are a number of cystic lesions that can occur. You can get mucoceles, which are the most common, accounting for 3/4 of the cystic lesions, and then you have mucus retention cysts, epidermoid cysts, benign lymphoepithelial cysts, and you get cysts in HIV as well, where you have lymphoepithelial cysts which are bilateral, So mucocele, as I said, is the most common lesion of minor salivary glands. It's seen more commonly in children and adults, young adults, where you get a dome-shaped bluish swelling, most commonly on the lower lip. So this results from localized trauma, which results in the rupture of a salivary duct. And here you can see that this pink material here is the spillage of saliva into the surrounding tissue, which just gets accumulated and compresses the normal salivary gland. And this cyst-like space is usually, because it's caused by rupture and trauma, so there's going to be a reaction, and so this space is lined by fibrous tissue or by inflammatory granulation tissue as a response to injury, and it gets filled with mucin, and inflammatory cells like histiocytes and come on here to try and ingest this mucus that is present. The adjacent salivary gland would show features of chronic sialadenitis, and again the ducts would show squamous or oncocytic metaplasia. The differential diagnosis of a mucocele is a mucus retention cyst. This occurs more commonly in the major salivary glands and not in minor salivary glands. This occurs by obstruction of the duct by a sialolith or by any thick inspissated secretions. And because of obstruction of the duct, the portion proximal to it gets obstructed, and the mucus accumulates within the lumen of the duct. So the dilated duct is actually what forms the cyst wall, which is why this cyst has an epithelial lining, unlike the mucocele, which does not. So this is a true cyst, and the lining is squamous, cuboidal or columnar epithelium. It again contains mucus, and macrophages are present, which again come here to ingest this mucus. Benign lymphoepithelial cysts, here this is a specimen of the parotid, where you can see that there is a large cyst which has a shiny wall because of mucus within it, and this is a unilocular cyst which is lined by either columnar or squamous epithelium, and it is well demarcated from the salivary gland by fibrous tissue. Now why it's called a lymphoepithelial cyst is, you can see here these are lymphoid follicles which can have germinal centers, and these are present just below this epithelial lining, giving the name of lymphoepithelial cyst. How we differentiate this from HIV associated lymphoepithelial cysts is that in HIV these cysts are bilateral, they are multiple, and the lymphoid tissue shows much more florid hyperplasia as compared to that in benign lymphoepithelial cysts. And in HIV you also get accompanying tonsillar and cervical lymph node enlargement. There are a number of theories of how this lymphoepithelial cyst arises, which include whether they are derived from embryological branchial cleft remnants which represent parotid branchial cleft cysts, or whether the salivary duct epithelium got entrapped within an intraparotid or a periparotid lymph node, or a salivary duct cyst which recruited lymphoid component. So we are still not clear on how these lesions arise. Next we go on to the inflammation of salivary glands. Again, sial is salivary and adenitis is inflammation. So sialadenitis refers to inflammation of the salivary gland. This again can be acute sialadenitis, which is usually caused by viruses like mumps, Epstein-Barr virus, influenza viruses. And what you get here is that you have epithelial. This is again an FNAC where you see some epithelial cells along with a lot of neutrophils. So once you see neutrophils, you can call it an acute sialadenitis. The others are chronic sialadenitis, where you would get lymphocytes rather than neutrophils on an FNAC. Then you have granulomatous sialadenitis, and you have this entity called chronic sclerosing sialadenitis, which is an IgG4 related disease. So you must be aware of IgG4 related disease, and the same morphological features are seen in a wide spectrum of organs within the body, in the retroperitoneum, in the pancreas, in the thyroid, in the salivary glands, in the lacrimal glands. So that is the spectrum of IgG4 related disease, and it also includes chronic sclerosing sialadenitis. So chronic sialadenitis is also called lymphoepithelial sialadenitis, and it is seen in association with Sjogren's syndrome. It's more common in adult females than in males, and it presents as recurrent firm multinodular diffuse enlargement of the salivary glands, which is frequently bilateral. On microscopy, the lobular architecture of the salivary gland is maintained, and this is very important. Whenever you see lymphocytic infiltrate within the salivary gland, it could be benign, which is an inflammatory condition, or it could be malignant, which would be a lymphoma. So how do you identify is this benign or malignant? You look at the lobular architecture. Whenever the lobular architecture is preserved, that is because it is a non-infiltrative infiltrate, or a benign infiltrate which does not cause destruction of the tissue but only insinuates itself into the preserved architecture, whereas lymphoma would cause destruction of the tissue and the lobular architecture would be lost. So here in chronic sialadenitis, you get diffuse to focal lymphoid infiltrates, you can get lymphoid follicles. There is a loss of acini because of atrophy and degeneration of the glandular elements. They form these epithelial complexes along with the adjacent myoepithelial cells. They are called epimyoepithelial islands, and these are infiltrated by lymphocytes, as you can see here, and you can see the surrounding lymphoid infiltrate as well. This is an FNAC, and here you can see these are the salivary acini. They are showing lymphocytic infiltrate. You can identify lymphocytes, and here these are plasma cells which are totally different from neutrophils which you saw in acute sialadenitis. Again, here you are seeing some metaplastic changes. So how do you differentiate from the most common lymphoma, which is a maltoma or extranodal marginal zone B-cell lymphoma? This would cause, like I said, loss of lobular architecture, and the lymphoid cells are large. They are larger than normal lymphocytes, and this would also spill out of the capsule into the adjacent fat. So that would again help you to identify it as malignant. Coming to IgG4 related chronic sclerosing sialadenitis, this is an immune mediated chronic fibroinflammatory disease, also known as Kuttner tumor in the submandibular gland. And in all the organs that are involved, you see the similar microscopy, which is sclerosing lesions which show lobules which are separated by thick fibrous bands. You can see these lobules here, and the pink areas are thick fibrosis. This fibrosis has a very peculiar architecture, as you can see here. It's called storiform fibrosis, which means it has a pinwheel like architecture. So you can see the same thing here with a lot of whirling of these spindle cells, and in between you have the lymphocytes. Along with that, you get periductal lymphoid infiltrates, like you see here. This is a ductal structure which is surrounded by dense lymphoid infiltrate. The infiltrate is rich in plasma cells, and these plasma cells produce IgG4, which can be detected by immunohistochemistry. And along with this, now you also get phlebitis, obliterative or non-obliterative phlebitis. That means there is an inflammation of the veins which leads to obliteration of the veins, the lumen of the vein. As you can see here, the wall is thickened and you cannot identify the lumen. And we can do a special stain for collagen. This is Wohoff Van Giesen, which shows the abundant fibrosis around the vessel walls in red. Now, why it's very important to identify this disease, although it can present as a mass, because it's a sclerosing lesion, there's a lot of fibrosis. You can have a mass lesion and it has ill-defined borders, so you're really not able to identify it as benign or malignant. But if you identify this on a biopsy, it's very important, because these patients respond very, very well to steroids and to rituximab. So the lesions would drastically resolve once you start the treatment. So that is why it is very important that you either identify it on an FNAC or a core needle biopsy, and you don't go for a resection of the mass. Next, coming to granulomatous sialadenitis. In our country, the most common cause of granulomatous inflammation at any location is tuberculosis. But you can also get granulomas in the salivary glands, in sarcoidosis, in fungal infections, and also when you have a mucocele or when there's extravasated mucin, you can get a reaction to extravasated mucin in the form of granulomas. So this is how granuloma looks on FNAC. You can see the epithelioid histiocytes which have the slipper-shaped nuclei, and this is large multinucleated giant cells. You might recall the nuclei arranged at the periphery, that's a Langhans giant cell. Next, we go on to salivary gland neoplasms. This is the WHO classification of salivary gland tumors. So you can see that there are more than 50 entities, and most of them have a lot of overlapping morphology, which makes it difficult to diagnose them. So salivary gland neoplasms account for about 1% of all tumors. However, this number is low as these are considered to be underreported. They are more common in adults, and like I mentioned, fine needle aspiration cytology is the first line diagnostic modality for these masses, because they are superficial masses and they are easily amenable to putting a needle into them, and You just stick a small needle into the mass and you get a lot of material, which gives you a lot of information. And salivary gland tumors have been really studied well in FNACs, so it is possible to make a diagnosis of benign versus malignant very easily. Beyond that, common tumors can easily be identified on FNAC. However, the rarer ones, you might be able to say that yes, this is cancer, but not exactly type what kind of cancer it is. But you don't need that to manage the patient. What you need to know is this a cancer or not? How much do I need to resect the salivary gland? Do I need to just do an enucleation of the tumor, or do I need to do a radical parotidectomy? So FNAC really gives you all of this information. Little is known about the etiology of salivary gland tumors, and unlike in other cancers, molecular diagnosis has been slow to catch on. But in the last 2 decades, there have been major advances, and a lot of molecular alterations have now been identified in these tumors, which are important in making the diagnosis. The clinical stage is the most important prognostic parameter in salivary gland tumors, and also the pathological stage. So how we gross the specimen, what is the information we can give the surgeon once it's resected, is very important. So 70% of the salivary gland tumors are located in the parotid, and about 20% are in minor salivary glands. 80% of parotid tumors are benign, whereas in minor salivary gland more than 50% are malignant. So like sir already mentioned, the smaller the involved gland, the higher the possibility of the tumor being malignant. As I mentioned, there are so many entities, and this is an algorithm which has been reported to help you make a diagnosis, but as you can see, there's a lot of morphological overlap because tumors can show different types of metaplasia within them, and this makes diagnosis quite difficult. Which is why, as I mentioned, it is important to know what are the different cell types in the salivary gland and how they look, and because this would help you to move closer to a diagnosis, as each cell has a specific appearance. And again, we know which tumors arise from which part of the salivary gland structures, and this again helps us in making a diagnosis. You have a lot of ancillary tests like immunohistochemistry, which is something we do very frequently in all of our cases, and this again helps you to identify these tumors, as there are specific markers for each specific tumor. On histopathology, how do we identify benign versus malignant? Would anyone like to volunteer an answer? Okay, I haven't got an answer to the previous question as well. So I'll just go on. So when we look at benign versus malignant, we look at the rate of growth. Is it slow, or is slow growing, or is it rapid? What is the relationship with surrounding structures? In the parotid, is there a history of pain? Because if the mass is painful, that would tell you that the facial nerve is involved. We look at the circumscription of the tumor. If it is benign, it would have a capsule and it would be well demarcated from the surrounding salivary gland parenchyma. However, if it was malignant, there's no capsule and it has infiltrative borders. The exception to this is that benign tumors like pleomorphic adenoma, they can be multilobular, multifocal, they can lack a capsule, and they are even known to metastasize although they are benign. So if you look here, this is a section from the salivary gland, and these pink areas are the lobules of normal salivary gland, whereas these blue areas are the pleomorphic adenoma. So you can see here there are multiple nodules, and you're really not able to distinguish it from the surrounding salivary gland parenchyma, because these nodules are merging with the lobules of the salivary gland parenchyma. This again is part of the tumor, and it appears to have gone outside what is appears to be the capsule of the salivary gland. So is this malignant? No, it is not. So pleomorphic adenomas, what they do is that they send out pseudopodia, which are finger-like processes which grow in all directions, and although they would be connected to this tumor within the gland, when they are transversely sectioned in a single plane, it can appear to be that they have infiltrated beyond the capsule, and this is not attached to the capsule, giving an impression of malignancy. So again, as I said, you look at the margins if they are non-infiltrated or infiltrated. You look at the cytomorphology of the tumor cells, you look at the cell types, and that is how you identify which specific tumor it is. As I mentioned, now we have specific molecular alterations. So in each of these tumors, like mucoepidermoid carcinoma, epidermoid carcinoma, you have a specific fusion gene, and if you are able to identify this fusion gene, that would make the diagnosis for you. There are various methods for detection of these molecular alterations. You have fluorescence in situ hybridization, you have real-time PCR, you can, and as I mentioned, you can do immunohistochemistry. So some of these alterations like adenoid cystic carcinoma has the MYB gene fusion, you have in which you have overexpression of the MYB protein, and this MYB protein can be detected by immunohistochemistry, and this is a very inexpensive technique. It is done for every case in the pathology department, so this is really helpful in making diagnosis even if you don't have molecular testing. So as I said, salivary gland tumors are one of the most heterogeneous groups of neoplasms. So what role is there for FNAC in their diagnosis? It definitely helps to differentiate between neoplastic and non-neoplastic salivary gland lesions. In the case of a neoplasm, it can diagnose many common benign tumors accurately, and in carcinomas, it can help to differentiate between a low-grade and a high-grade carcinoma. So once you tell the surgeon it's a high-grade carcinoma, he's going to go for a total or near total parotidectomy. He's going to do a lymph node dissection, whereas for a low-grade carcinoma, lymph node dissection is not required. So this is basically how FNAC helps make decisions. The neoplastic salivary gland lesions are managed surgically, and knowing whether it's a low or high grade carcinoma or if it's a benign tumor will help to determine the extent of the surgery, whether the facial nerve needs to be preserved, and whether neck dissection is indicated or not. Overall, fine needle aspiration cytology has a sensitivity of ranging from 86 to 100% and a specificity ranging from 90 to 100%. But when you look at the ability to differentiate neoplastic from non-neoplastic, it has a diagnostic accuracy from 80 to 100%. However, while making a specific diagnosis, as in specifying what tumor type it is, the accuracy is a little lower. Compared to core needle biopsy, FNAC is preferred because it's a less invasive technique. With core needle biopsy, it has been reported that malignancy does occur in the needle tract, and this was one of the major disadvantages. But with improved needles being available, this also has reduced. So if an FNAC doesn't help you, you can go ahead for a core needle biopsy, but you have to make sure that you do a guided ultrasound guided needle biopsy to avoid injury to the facial nerve. The FNAC gives you faster results, and clinical management can be determined rapidly. You can get an FNAC result on the same day. The cytological features of the cell, whether the cells are benign or malignant, what kind of cytoplasm they have, what kind of nuclei they have, how the chromatin looks, that is better appreciated on FNAC, whereas on histology you can see the architecture, the maintained lobular architecture, the loss of architecture, architectural patterns, invasion are better seen on histology. FNAC can be assessed on site. This is known as rapid on-site evaluation. When the procedure is done, the pathologist can see the slide immediately and tell you whether your specimen is adequate or not, whether you need to take some more passes to get more material to make a diagnosis, to get more material for molecular testing. So this is known as triage of the specimen, which can be done on rapid on-site evaluation, but this cannot be done for a biopsy, and it would take you 3 days to know whether the material you've got in the biopsy is adequate or not. So this is how it's done. Once the aspirate is taken, it is stained by dipping it in various vials of stain, and immediately the pathologist can look at it and tell you whether you have material or not. So recently we have a new FNAC reporting system, because there was some confusion in reporting because of the diversity of the diagnostic categories, and there was the risk stratification and communication with surgeons was not great. So there was a need to define a set of diagnostic categories for salivary gland FNA, which would give you an implied cancer risk and tell you that if this is in, say, category 1, the risk of cancer is low, whereas if it's in category 6, the risk of cancer is high. So this is known as the Milan system for reporting of salivary gland cytology. There are 6 diagnostic categories, and each has an implied risk of malignancy, and it tells you how to manage the patient further. Now we look at the histology of specific tumors. Benign tumors, as I mentioned earlier, pleomorphic adenoma is the most common salivary gland neoplasm. It accounts for 70% of parotid tumors, where 90% occur in the superficial lobe, and 50% of submandibular tumors, and also 45% of minor salivary gland tumors, where the most common site is the palate. They're seen in 4 to 6 decades, more common in females. It's a slow growing painless mass, and it can grow to very large sizes, as you can see here in this patient. It's called a benign mixed tumor. It's called mixed because it has an admixture of epithelial cells, myoepithelial cells, and a very typical chondromyxoid stroma. So here you can see the gross. Because of this chondromyxoid stroma, chondro means cartilaginous, myxoid means having an appearance like mucus. So because of this cartilaginous mucousy appearance, it has a shiny cut surface. You can see that it's very well demarcated here from the rest of the salivary gland. When it's present in a minor salivary gland, it could be unencapsulated because they don't form capsules there. So here this is a recurrent pleomorphic adenoma where you can see multiple tumor nodules and of varying size here as well. On microscopy you can see that it is usually well demarcated with a nice capsule separating it from the normal salivary gland, which is seen here at the periphery. This is the fibrous pseudocapsule. It again has this blue appearance because of the chondromyxoid stroma, which looks quite like cartilage. It frequently shows cystic change, and as I said, you can get pseudopods. So here you can see how these pseudopods, this is the capsule, it pushes out a finger-like process which then develops a capsule around it. And if one of these is going obliquely and you see it in this section, in this one plane only, it looks like you have a separate nodule on the outside, but this is actually just one of the finger-like processes which is cut off in a different plane. Along with the stroma you have epithelial structures which are tubules which appear to be melting into this chondromyxoid stroma. Now because you have both epithelial cells and myoepithelial cells, and you have the stromal component, each of these three can show metaplasias, they can show variations. One might be more prominent and the others not present. So all of these variations can make the diagnosis very challenging. So you can have very cellular tumors which lack the matrix, and they can have prominent metaplastic components which make it difficult to identify. So here you can see this is squamous metaplasia with formation of keratin pearls as you get in squamous cell carcinoma, but these cells here are benign, they are not malignant. You can get a lot of epithelial structures without any chondromyxoid stroma, and this here is bone, so you can see that it's invaded into bone, but that's only because of its pushing nature and not because it has infiltrated. Here you have the chondroid appearance, these are the epithelial structures, and here is the pseudopods which are pushing out into the capsule. So you can get a lot of different appearances. And you can also see these nice floret-like tyrosine crystals which can help to make a diagnosis. They look really pretty. You can get mucinous metaplasia. When you get mucinous metaplasia, it makes you think of a mucoepidermoid carcinoma because these mucous cells are what are seen in mucoepidermoid carcinoma. But you have to appreciate the cytology of these cells, that they are benign, they don't have any nuclear pleomorphism, they don't have any mitosis, there's no necrosis. So all of those features would help you to distinguish from a carcinoma. On FNAC you see all of these features as well. This nice purple staining matrix is the chondromyxoid matrix, which has a typical appearance known as troll hair appearance. So this is exactly what it looks like. These are the myoepithelial cells which are spindle shaped, or they can be plasmacytoid shaped, and this appearance is called likened to a sea of turtles on a beach. So a lot of descriptive terminology for pleomorphic adenomas. Pathologists like giving everything names, I guess. So here you can see squamous metaplasia which mimics mucoepidermoid carcinoma. You can get hyaline globules which are typically seen in adenoid cystic carcinoma. So these features, when they're present, might make diagnosis difficult, but as I mentioned, you have specific genetic alterations. So in pleomorphic adenoma you have the PLAG1 gene rearrangement. So PLA will help you remember pleomorphic adenoma, PLAG1. So this can be detected by FISH or by immunohistochemistry, and it's very useful to differentiate from other lesions which might resemble it on histopathology or on cytopathology. Pleomorphic adenomas are benign, but they still do recur in a significant proportion of cases. That is because these tumors are usually enucleated, and when enucleation occurs, there can be spillage of tumor in which stays in the tumor bed and then grows, or you can have pseudopodia which are left behind because they are extending outside the capsule. And sometimes you just have abundant chondromyxoid stroma. It has a consistency like mucus, which is why it just spills over and stays behind and is difficult to remove. Pleomorphic adenomas are known to undergo malignant transformation, and that is known as carcinoma ex pleomorphic adenoma, or carcinoma arising in a pleomorphic adenoma. This occurs in older patients who have longer standing tumors, who have which are in submandibular location, large size of tumors, and these are the risk factors for this. Next, coming on to the second most common benign tumor, Warthin tumor, which was previously known as papillary cyst adenoma lymphomatosum. Very complicated name, you don't need to remember that anymore. It was also known as adenolymphoma. It's most commonly seen in the parotid, where it occurs in males, typically in elderly males who are smokers. This tumor can be bilateral, it can also be multicentric. Very often, in 3% of cases, it is associated with other neoplasms, so you can get other benign or malignant tumors along with a Warthin tumor. So it presents as a doughy cystic painless mass, which is grossly, it has an encapsulated smooth surface. You can see on the outside that the surface is quite smooth, but on the inside you can see that there are small lobules or projections on the inner surface, which appear whitish in color, and this you will see on microscopy is because of the number of lymphoid follicles that are present. So these are the lymphoid follicles, which are lined by a double layer of cells. The epithelium here has an inner columnar or cuboidal layer, or inner columnar layer and an outer cuboidal layer, and both of these can be stained with different stains for the abluminal and the luminal cells, but you don't really require IHC for diagnosis in this, and it's a really easy diagnosis to make on morphology as well as on histopath as well as on cytopathology. So on cytopathology, it has a very dirty or murky background here because of the cyst contents. You have sheets of oncocytic cells, which are flat polygonal cells, and you have prominent lymphoid component. Other benign tumors that arise in salivary gland are basal cell adenomas, myoepitheliomas, canalicular adenomas, to name some of them. And there is a much longer list, but the only important ones that you need to know are pleomorphic adenoma and Warthin tumor. So we'll go on to the malignant tumors. The most common one is mucoepidermoid carcinoma. As the name suggests, it has a component which secretes mucus, that is the mucus secreting cells, and it has epidermoid or squamous cells, and these components are present within this tumor within a variable proportion. So you have mucus cells, epidermoid cells, and cells which are intermediate between these two, known as intermediate cells, which are seen here. These cells with bluish material in the cytoplasm, these are the mucus cells. These here are the intermediate cells, and these cells with pink cytoplasm are squamous cells. It's the most common malignant salivary gland tumor, most common malignant salivary gland tumor in children, and most frequently seen in the parotid. However, it can occur in the oral cavity, it can occur intraosseously inside the mandible, and in all these sites it presents as a painless low growing mass however, on occasion it can present with pain and numbness. It's an infiltrative tumor where you see cystic spaces which are filled with mucin excuse me, and they are lined by a variable proportion of mucus cells, along with which you have the epidermoid cells which form solid nests. And you can also get a lymphocytic infiltrate that you see over here, which is known as tumor associated lymphoid proliferation. And you have different stains which can help you to pick up each of these epithelial components if you cannot identify them by inspection of the slide alone. Again, you have a characteristic fusion is the CRTC1 MAML2 fusion, which is seen in about 70% of cases. So this is how you detect it, by fluorescence in situ hybridization. This is a break apart fish probe. So normally you have the a probe which is present, one signal is present on each side of the CRTC1 gene, but when there is a fusion, the CRTC1 gene is broken into two parts, which is why the signal is split, and this is known as a break apart fish probe. Next we'll come to adenoid cystic carcinoma, which is the second most common malignant salivary gland tumor, seen with equal frequency in major and minor salivary glands, and it is the most common malignant minor salivary gland tumor, with the palate being the most common site. Again, this is more common in females and seen in the 4 to 6 decades of life. Patients present with a slow growing mass. This tumor has a very high propensity to invade the nerves. So small nerves which are present are frequently invaded, and then it grows along these small nerves to the larger nerves and can reach the facial nerve and invade it, which is when the patient has tenderness and pain. So this develops from both the myoepithelial cells and the ductal cells, so it has a divergent phenotype. On microscopy, it has this very characteristic appearance, which is a cribriform architecture with these punched out spaces, which is known as Swiss cheese appearance. And although this is a characteristic feature, it might be present in a very small proportion, and it can get only solid areas or only tubular areas. Like I mentioned, there's a lot of perineural invasion. So here this is a nerve, and you can see the tumor is growing around the nerve, and here it is also growing inside the nerve. Again, you have immunohistochemical markers, and you have this translocation involving the MYB or the MYBL1 oncogenes, and the fusion protein MYB can be detected by immunohistochemistry. So if you're finding it difficult to make a diagnosis, these tests will help you. On FNAC, you get these nice pink globules of extracellular matrix material to which the cells are adherent. And these are called hyaline globules, and they are quite characteristic of this tumor. There is a grading system with grades 1 to 3, so grade 1 being the best and grade 3 being the worst, and it has a very poor prognosis, grade 3, as compared to grade 1. So although it's a generally indolent tumor, the long-term prognosis is poor, with a 5-year survival of only about 60 to 75%. There's frequent late local recurrences. You can have late onset metastasis, and occasionally it can undergo high-grade transformation as well, when it can metastasize to the lymph nodes. Other tumors, which other carcinomas include secretory carcinoma, which again has a specific genetic alteration. And why it's important to identify this alteration is that the tumors which have this alteration can be treated with pan-TRK inhibitors. Drugs are available which specifically target fusions of the NTRK genes, and these can be used in these patients. Next, we'll go to carcinoma. X-pleomorphic adenoma, which I mentioned, is a carcinoma which is arising in the background of a pleomorphic adenoma. It's most common in the parotid. So the risk of malignant change in pleomorphic adenoma is 1.6% in the first 5 years, but if it's a long-standing tumor, the risk increases to 9.5% after 15 years. So the classical presentation is that of a long-standing painless mass which undergoes sudden enlargement, or there are multiple recurrences of a benign pleomorphic adenoma, and then the last recurrence would be malignant. These tumors would have fixation and ulceration of the overlying skin. You can see here there's a very large tumor, and they present with facial nerve palsy and lymph node enlargement because of metastasis. So these are infiltrative tumors with large areas of necrosis, but you would need to identify a small area which has the pleomorphic adenoma within this large tumor to make a diagnosis of carcinoma X pleomorphic adenoma. So like you know that in many other tumors, classically like in colon cancer, you have the pathogenesis shows that there's a multi-step carcinogenesis. So the same also applies to pleomorphic adenoma. First you have a proliferation of cells within the ducts itself, and that is called intraductal carcinoma X pleomorphic adenoma, and then after that these malignant cells, which are initially intraluminal, they move out into the beyond the duct into the surrounding tissue, and then beyond the salivary gland into the adjacent fat. So this is the progression of carcinogenesis in this tumor. Lastly, we also have to always keep the possibility of metastatic tumors to the parotid in mind, because we know that the parotid has a number of intraparotid and periparotid lymph nodes, and these lymph nodes serve as the first echelon node, draining the skin over the root of the nose, the eyelids, the frontotemporal scalp, the external auditory canal, part of the tympanic membrane, part of the floor of the nasal cavity, parts of the palate and nasopharynx. And which is why, because they drain all these areas, any malignancy in this area can drain to the intraparotid lymph nodes. The parotid is therefore about 20 times more frequently involved by metastasis than any of the other major salivary glands, and metastasis to parotid account for about 8% of all malignancies. So metastatic tumors to the parotid can occur by direct extension. You can have hematogenous spread, you can have lymphatic spread. And when we look at Western literature, the most common metastasis to the parotid are cutaneous squamous cell carcinoma and melanoma. However, these are not so common in our country, and over here eyelid tumors and other ocular tumors like retinoblastomas do frequently metastasize to the parotid. So to conclude, salivary gland lesions are a very heterogeneous group of diseases, and within the tumors itself there's such a vast spectrum, and it often makes diagnosis difficult. Preoperative diagnosis can be made by fine needle aspiration cytology or by core needle biopsy, and this helps you to distinguish between a non-neoplastic versus benign versus a malignant tumor. Within a malignant tumor group also you can identify low grade versus high grade tumors, and this would basically tell the surgeon how to proceed, what is the extent of surgery, whether the nerve can be preserved, and whether you can do whether you need to do a lymph node dissection or not. You have IHC, which is an adjunct which helps in improving the diagnostic accuracy, and you have molecular testing which helps in diagnosis, in prognostication of these patients, because some genetic alterations are associated with worse outcome, and most importantly some of the genetic alterations are predictive of response to targeted therapy. So we know that in future everything is going to be about targeted therapy and personalized drugs for each patient, so that's when molecular testing is going to be really important. So pathologists play a very important role in diagnosing and giving you all this information from the tumor tissue. And not only is the pathologist's role important, but communication between the pathologist and the surgeon is critical for good management of each patient. So here you can see I spend a lot of time with my colleagues from ENT, and it's very important to have good communication between different specialties that are involved in the management of patients. Any questions? Okay, I guess not. Thank you.